Yes, good day, good morning, good evening, good night, depending on wherever you are. It's a good day today. We're going on learning about our topics. Topic of today is persistent depressive disorder. Persistent depressive disorder. Yesterday we dealt with major depressive disorder and we managed it and we talked a lot about it. Yes, you understand. Major depressive disorder, we said it's about uh, it's about depression. That is what people always call depression. We saw how hormones and neurotransmitters over to the brain can lead to what is happening. Yes, yes, yes. Now, today, as we embark on the topic of today, as per what you've seen, we are dealing with persistent depressive disorder. Persistent depressive disorder. What is the name of persistent depressive disorder? How can we say what is persistent depressive disorder? The other name for persistent depressive disorder is called dysthymia. Dysthymia. Dysthymia affects children so much. This is a complication that is affecting children a lot, and we should check and look up and see check about it as we go on. What is? Let's ask. Okay, let me connect something a little bit here. Yes, yes. Now we are okay. We can continue. Now, let's talk about persistent depressive disorder, PDD, persistent depressive disorder, PDD. What is persistent depressive disorder, also known as dysthymia? Is a chronic form of depression characterized by a depressive mood lasting for at least 2 years, lasting for at least 2 years, or 1 year in children and adolescents. Yes, in adult, you will see it goes to at least 2 years. Yes, but in children and adolescents, this is a depression characterized by at least 1 year in children and adolescents, along with other symptoms of depression. You saw we went through symptoms of depression. Yes, you remember the symptoms of the depression. We talked about them last time, and we said, yes, loss of mood. We can go through them again so that someone who was not with us last time can uh, can 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 let me see, we go through them again so that someone uh, someone can be with us who is seeing this video today can know what to do. Now, yeah, the symptoms of depression, we saw there are nine. We saw there are nine: depressed mood most of the day, nearly every day. That is the first one. Markedly diminished interest in pleasure activity, that is second. Significant weight loss or gain, yes, or change in appetite. Psychomotor agitation and retardation, that is the fifth. Insomnia or hypersomnia, that is, we are dealing with sleep disturbance, fatigue or loss of energy, that is second. Feeling of worthlessness or excessive guilt, that is seven. And then we have difficulty in concentration. Difficulty in concentration, yes, you can see that is uh, difficulty in concentration or making decisions. Yes, that is eight. Feeling worthlessness, we talked about it. Recurrent thought of death or suicide, that is another one. Now we are going on well. We are going on well. Just a minute. A minute. Some connections problems, some connection problems. Yes, 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 yes. Good, good, good. We are okay now. We are okay now. Connection problems, I have dealt with it. Yes, we have gone through the diagnosis of depression, and you've seen the diagnosis of depression. That is what you should look at. Now we go to persistent depressive disorder. We have said it's a chronic form of depression characterized by depressive mood lasting for at least 2 years. That is in children, along other symptoms that we have gone through. We have seen the symptoms that we have gone through very well, the symptoms that we have gone through, and so typically less severe than major depressive disorder. Most of this persistent depressive disorder is less severe than major. It's more enduring and can significantly impair functional and quality of life. Yes, every depression, as we saw, it can impair function of life. Just a minute, connections are disturbing, and we need to be clear for our audience. We need to be clear for our audience to be reached well. Yes, 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 yes. Now we go on. Yes, very nice. Now, connections are coming clear now. Yes, 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 yes. Yes, we have seen that definition. Persistent disorder is a long-lasting depressive condition, a depressed mood most of the day for more than for more for more days than not. Duration is more or less than 2 years in adults, 1 year in children and adolescents. Now, in the DMS5 diagnostic criteria, we saw what is DMS5. For those who are new, DMSI is a revised edition that we go on, look at it. It's like a book that we go look and how it helps us diagnose mental issues. It helps us diagnose mental issues. Now, in persistent depressive disorder, this is less severe than major. So in this one, we will see presence of poor appetite or overeating. Some people, when they are depressed, they have poor appetite. They become skinny, or sometimes they really overeat. Yes, insomnia or hypersomnia. There is insomnia, lack of sleep, or you are sleeping a lot. The opposite is the true in some people. Low energy and fatigue, low self-esteem, poor concentration, or the difficulty in making decision, feeling of hopelessness because now you are depressed. Presence of these 6 symptoms in less than 2 years may feel that this person is having persistent depressive disorder. Less than this, you may tell us this person is having persistent depressive disorder. Now, let's go to criteria C. The criteria that we want to look at during the 2 period of years. The person has not been without symptoms for more than 2 months at a time. Criteria for major depressive disorder may continue present for 2 years. Yes, it may continue for 2 years. Imagine. It is less severe than major, but it may continue for 2 years. No manic or hypomanic episode. Yeah, excludes bipolar disorder. Now, bipolar disorder is not here. You exclude bipolar. We will talk about bipolar disorders when it comes. Now, this persistent depressive disorder, we have seen how you know this person has persistent depressive disorder. One, poor appetite or overeating, insomnia or hypersomnia. Insomnia is lack of sleep, hypersomnia is sleeping a lot, low energy and fatigue, low self-esteem. You see that you don't even have the courage to talk where people are. Poor concentration or difficulty in making decisions. You don't concentrate and you have difficulties in making decisions. And then your hopelessness. Now we continue on subtypes of this condition. The subtypes of this condition, this one is pure dysthymia syndrome. Full criteria form all those symptoms you have seen, but they have to last for 2 years. That is pure. All those we have seen, You sleep a lot, you get it, your hopelessness, yes, you all those, the feelings of hopelessness, poor concentration, low energy and fatigue, they are six. You have all those. That is, you have all those. That is pure dysthemic syndrome for 2 years. Persistent major depressive episode, full criteria, you have full criteria of major through 2 years. And then we have intermittent major depressive with or without current episodes. It is intermittent. You have some stress, you can get like two episodes like insomnia and hopelessness. You get it? That is intermittent. Like two, you have two symptoms. That is intermittent. Yes, and then we go to causes. Causes of this persistent systemic criteria. Yes, persistent the systemic. Yes, we go to causes. Causes, we will find that you have biological factors. We talked about neurotransmitters. The other video, we talked in details about neurotransmitters, about serotonin, dopamine, yes, and neuroperipherin. We looked at serotonin. I said I call it a happy hormone because it gives you mood and good vibes. And then dopamine, yes, we talked about pleasure. You remember? Yes, yes, yes. In that video, go to that video, revise it. You'll know how these things make you feel and how these things make you feel better. And then we saw neuroperipherin. You remember me saying neuroperipherin? I'll give it a sister name of her sister who's adrenaline. Yes, that one. Neurotransmitters imbalance is, of course, genetic predisposition. Yes, there are some people who have this condition genetically. We find their bloodline or their genetic makeup, they release low serotonin. It's in their genetic makeup. Yes, neuroendocrine dysfunction, HPA axis deregulation, neuroendocrine dysfunction. You remember HPA? Yes, it is in that video, the previous one. It's good you go through it so that you understand. But my friends, if you want to understand this, you start from the first video. You will come with us very clearly, very softly, and you will understand bit by bit, because most of these things are explained better from previous videos. Now we go to that is biological factors may be a cause, psychological factors, negative cognitive style. Yes, negative cognitive style. You have negative cognitive. When we talk of cognitive, we are talking about brain and capabilities. Yes, low self-worthlessness. You think you are not worth it. Yeah, yeah. Learned helplessness. Learned helplessness. You learn. It's not learning, learn helplessness. Those are psychological factors. And then we go to social environmental factors. Social environmental factors. Chronic stress. Yes, chronic stress, e.g., poverty, family dysfunction. Yes, family dysfunction. In your family, there are problems. We know most of the things that we deal with are families. In families are problems, and the problems in families, we bring them to the public by showing people we have problems in our family, which is not really okay. Which is not really okay. We should deal with these things. Help, talk, 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 talk. I usually say talking is releasing some of your problems. Talking is releasing some of your problems. Yes. Childhood traumas, family. Let me talk about childhood traumas. When you are parents and you are fighting a lot, your children suffer, and this is trauma. It is very good as an adult to know how to solve your issues as adults by not including your children in the fights. Let your children not see you fight. There are some things you can control and do them privately that may not affect children. Even if it comes to separations and some other issues, let's do them amicably. We are raising kids that are traumatized. You see, that is not good. Raising kids that are traumatized and bringing kids up that have childhood trauma that may go up to the its lifeline, and they are going up to the when the kid is being an adult is not good. People suffer in adulthood because of childhood trauma. So as parents, let's help the children not to suffer childhood trauma by knowing how to solve. But if you see you have a neighbor or a family member who doesn't understand, you as a person who understands mental health, please you try and help them. Try and come in and help that couple so that these children that are being brought up can be having a good future, future as an adult and reason well. Yes. And then there is the last one in social and environmental factor, social support. I've just talked about you who knows what is happening. Don't smile and clap when people are fighting. Come in, be the bigger picture, try and help that person, help that couple, help those children indirectly by telling the parents, why can't you hide these fights you have in front of the children? Mm. Childhood trauma include some things like rape at childhood. Yes, when children go on through these, girls, it is carried up to adulthood, and it makes some children fear. Mm? Fear to be around men. Yes, it's not good. Very bad. Very, very bad. Now, as adults, we need to help each other because some things adults go through, they make them explode, and when they explode, they forget the children are watching. No, it's not a good thing to do that. Let's go to differential. What are other things that may be confused with this persistent mood disorder? The major depressive disorder may be confused by this major. But you see the difference between major has so many issues that we will see about it. Yes, we have seen bipolar disorders. Someone may confuse bipolar disorder by by persistent depressive disorder. Wait a minute. Yeah. See. Yes, you don't have to confuse this condition with uh, with uh, with bipolar. Cyclothymic disorder. We will see about cyclothymic. We are coming on that. Those are which might be confused. Medical conditions such as hypothyroidism. You see, when someone has a problem with an organ that is bringing the dysregulation and mood disturbances, you don't confuse it with this because when a person is having hypothyroidism, this person may display issues like stress disorders. Now, let's see the differences between major depressive disorder and persistence. In in MDD, which is depressive disorder, a mood disorder with episodes of severe depression. Yes, a chronic form and persistent is a chronic form of depression with long-lasting low moods. You see that? With severe episode with long-lasting low mood. Yes, duration, yeah, of major depressive disorder at least 2 weeks. But you see, in persistent depressive disorder, it's a 2 years, and more severe in major and milder symptoms but chronic in persistent. In major, there are more severe symptoms, but in chronic, persistent is chronic, mild but chronic. Cause may full recover in major between episodes, but chronic continuous symptom is few periods of normal mood. Yes, you see the difference? No symptoms in major depressive disorder, loss of interest, guilt, suicidal thoughts, weight and appetite changes. loss in persistent low self-esteem, hopelessness, low energy, poor concentration. Yes, we have seen that. Now we go to brain function. Brain function in persistent depressive disorder. Your brain in persistent disorder, disruptive, this persistent depressive disorder, reduced activity prefrontal cortex. You see, we are still talking about prefrontal cortex linked to decision making and mood regulation. So frontal cortex is linked to decision making and and mood regulation. Yes, overreacting in the amygdala. I'm still talking a bit about amygdala. Amygdala associated with negative emotions. Yes, overreacting in amygdala. This is associated with negative emotion. Impaired connectivity between mood regulation and brain regions. The connection is gone. Yes, we go to management. Today we will do two topics. Major was a big topic, but today we try and go up to the second one. Yes, management of persistent depressive disorder. We usually say psychotherapy is the key management criteria. Psychotherapy, cognitive behavior therapy, target negative thought and cognitive distortion. Teachers coping strategy, talk to them. Cognitive behavior therapy, cognitive. Yes, interpersonal therapy, focus on improved relationship and resolving life stressors. So it focuses on revolving, yes, physiodynamic therapy, explore resolution conscious physiodynamic therapy, explore and resolve unconscious conflict from early life. You see, you go back to the early life, you try to know what was happening, what happened, so that you come and resolve by talking out, helping this person to move out of what happened. It will take time, but it happens, it helps, yes. But when we come to pharmacotherapy, and I say it again, these drugs are not bought over the counter. You need to see a doctor to clarify which type of drug you should take, because some people may confuse antidepressants with antipsychotics, and you may take them. And if you take antidepressant and you really need to have a choice to take antidepressant, it will explode. Now, I will go through them in case of a person who needs to do an exam or a person who needs to understand the drugs that this is taking. Now, first line antidepressant, selective serotonin reuptake inhibitors, selective serotonin reuptake inhibitors, SSRIs, fluoxetine, sertraline, escitalopram, escitalopram. Yes, we have seen that first line is R helps mood changes, and then other serotonin norepinephrine reuptake inhibitors, valsartan, duloxetine. They block the destruction of norepinephrine. You get it? Selective serotonin, like MAO, they stop the destruction of serotonin. When a person is in depression, these hormones or these neurotransmitters, they are broken down faster. So this one, they stop they, they stop a chemical called MAO, so that this one, they stop that, so it cannot break down or catalyze in breaking down the 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 the, the hormones that are that like serotonin. Yes, they stop them. They stop them. Now we go to tricyclic antidepressants, or mouse. Yes, mouse. We have just talked about mouse. Less common due to side effects. Yes, yes. Augmentation. Some people take amitriptyline. Yes, you have seen the work of amitriptyline. I say they stop the breakdown of this hormone so that they can be at a good level to augment the effect. Augmentation strategy, adding bupropion, a typical antipsychotic, or lithium for resistant cases. Yes, we've talked about these drugs. This is not the first time. You see them in the other. topics. They are really, we went down through them and we explained how they work. Lifestyle intervention like regular exercise, good sleep, social hygiene, engagement, social engagement, avoid alcohol and recreational drugs. Drugs and alcohol. Drugs and alcohol. Please avoid drugs and alcohol. Avoid overdoing them. Stop taking cocaine and other drugs. Monitoring and follow up. Yes, you should monitor and follow up. Follow the person. Know how this person is. Don't let this person be in a relapse. Yes, medical. So look for side effects, suicide and risk of monitoring, long-term support to maintain missions. Yes, so today we have gone through persistent mood disorders and we have seen the difference between major and persistent mood disorder. Now, as we talk of persistent mood disorder, the other topic that we may go to after persistent mood is disruptive mood dysregulation disorder. Next time, we are going to talk of premenstrual dysphoric disorder. Premenstrual dysphoric disorder. You see, this is a very large topic and we need to have time when we come to talk about it. So today we will deal with disruptive mood dysregulation disorder, and then tomorrow we will come to help our sisters, help our sisters, our ladies who are struggling with the mood swings when it comes to their periods. Yes. We really need to be part of them. As men, we really need to help them. We really need to pamper them with love because this is something that is physiological that is turning to psychological. Yes, that tomorrow everyone who is a man, who is a lady, be here that we get to know how we can help and assist when it comes to these periods. Now let's go to the next topic. The next topic that we are going to learn is disruptive mood dysregulation disorder. Disruptive mood. You've seen, we have said of disruptive. Disruptive. When you talk of disruptive, you understand. DMDD is a childhood mood disorder characterized by severe, chronic, severe, and persistent irritability, frequent tempers, outbursts, and that are out of proportion to the situation, that are out of proportion. Children, parents that you have children, yes, children who have this, and you see at times they are chronic, severe, and persistent and irritable with frequent outbursts of tempers. Hey, crying out loud, throwing yourself down, rolling on the floor. Just know your child is undergoing disruptive mood dysregulation disorder. Hmm? Many parents will take the child, beat the child up, and other traditions they say this child is having bad spirits, is haunted. No, it's not being haunted. Let's know today that if you have a child who is undergoing this, your child is having a depressive mood disorder, and this depressive mood disorder is called disruptive mood dysregulation disorder. Disruptive mood dysregulation disorder. Okay, we are going on. I can see people are on the platform asking some questions here. Okay, now you have to answer them. So, yes, we are going on very well. Now, we have seen disruptive mood disorder. If you have a child who is having these problems, and the problems that we are seeing is this child is crying a lot, throwing himself on the floor, rolling around. You see, is not having a bad spirit. This person, this child is not haunted. This person, this person or this child is just having a clinical symptom that is signifying that he or she is having disruptive mood disorder. You see that? Very important, very, very important. Now we go on now to check on the criteria that will show us this person that we are dealing with is having a problem. What do we look at to know that this child, because we have seen it's a childhood mood disorder. We have seen it's a childhood mood disorder. How can we know that this child is having a problem? Features of this is severe high temper and outbursts, verbal or behavioral outbursts, yelling, aggression, aggression, throwing things around that are extreme. You sometimes think, what is wrong with this child? Yes, what is he this child obsessed? No, your child is not obsessed. It is a depressive disorder. That is the first sign that a child parents, you will get to understand this child is having this problem. And then frequency. How many times can this outbursts, how many times can this be? Outbursts can be less than 3 times per week. 3 times per week. In a week, or 4 times in a week, you will you will find this child having in 4 episodes, 3 episodes. Yes, you'll know this is now we are dealing with. Please tell parents that are out there, their children are not obsessed, their children are not having bad episodes, they are just having major depressive. No, they are just having a disruptive mood dysregulation. Yes, the dysregulation disorder. Now, frequency we have said is less than or equal to 3 times per week. And then irritable mood, persistent, irritable or angry most of the day, nearly every day. This child is very angry. If you give food, sometimes the child doesn't want to eat. If you talk to the child is not in the mood to talk to you as the parent or the guardian. The duration must persist at least 12 months with no break, for more than 3 months. At least 12 months with no break. That is the duration. And sometimes age of onset, the symptoms begin at the age of 10. You remember we learned about how developmental milestones. And in developmental milestones, we understood why. And you see why we had to learn developmental milestones? This is because it is helping us to understand where these problems come. Now, symptoms of this age is symptoms begin at the age of 10. Diagnosis age diagnosis age range only diagnosed between 6 to 18 years. 6 to 18 years. This is a problem that is for children, a problem that is disturbing our children, and this is a problem that we should help. Young parents are having a problem with this. They are really confused and they don't know what to do. Please tell them to talk to a person who knows what he or she can do. Now we go on to the set the setting. Symptoms occur in at least two settings: home, school, or peers. Home, yes, when they are playing with their friends, or peers, when they are having peers at home. Exclusion cannot coexist with bipolar disorders. Yes, they cannot. There is nothing like bipolar disorders with this mood dysregulation, disruptive mood dysregulation disorder. No, there is nothing. Intermittent exclusion disorder. No, there is no. Oppositional defiant disorder. No, we will see what those are. Now, the differential things that may look like they are like these ones are bipolar, opposition defiant disorder, which is characterized by its own and intermittent explosive disorder. Remember, we are dealing with the problems that are with children, for children, for children, for children. Yes, we are dealing with problems that are for children. Psychotherapy is the key management. Management, cognitive behavior, helping the child how to behave, very important. Parent management training. We will always train the parents in this because they are the parents or the guardian who is handling this child. So train the parents on how to handle the child, and then the other thing is you will see that some parents may lose hope. No, help them, talk to them, attach them to someone that can help the parents. Because when a child is having a problem, that problem is a problem of a parent. The problem lies to the parent. The parent is always having a problem in this. So please, 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 you will not exclude the parent because or the guardian. Yes, and school-based intervention. When we go to schools, we have therapies. Sometimes we go to school, we talk to these children, they carry the message home. Yes. So I would really love our government and governments out there. Please, governments, please invest more in interventions of mental health in children because they are the future. When we invest in good mental health in our children, we are bringing them up in a good way and we are carrying that generation as a good generation. Most of the problems you are having right now is issues of depressive disorders because the government did not invest well in these things. But as we go on, we should clarify and we should also help everyone. We should also help someone to change, help someone to revive. Yes, yes, yes. We have said school-based intervention. Medication, if needed, stimulants, methyl methylniodate, it has stimulant if ADHD coexist. Yes, if ADHD coexist, serotonin reuptakes like fluoxetine, yes, to improve in moods. We saw what serotonin does. A typical antipsychotics, risperidone in severe cases, risperidone, yes. Family support, education for parents and teachers, coexistence, structure, and behavioral reinforcement. Very nice, very nice, very nice. We have talked about our children. These are our future, and we should now look at the children that we are supporting and the children that we are helping out there. Please, 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 we talk to our children, we listen to our children, we know what our children need. Let's support our children. By supporting our children, we will have a very good and nice generation. Don't say that your child is obsessed. This child was brought up with a bad spirit. No, now you know when a child is having these symptoms that we have seen right there, we know that there is a problem that this child is undergoing and it's a medical problem. This medical problem can be helped. It can be helped and they change and they go on well and well. Now, if you need help, I will always say we are here and we have a group of people that I can connect to you and they will help you to do these things in a good way, medically and professionally. Yes, 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 yes. We talk next time. Very nice. Next time we are going to talk about our women. And I've said, I'm repeating it, we cannot have women without men. Problems of women is a problem for a man. Yes, because when a woman is having a mood swing, is a problem to his or her man. So let's be prepared for tomorrow's edition. It's a very wide edition. It's it's a disorder. It's a premenstrual dysphoric disorder. Premenstrual dysphoric disorder. Tomorrow we are going to talk. When we are talking about menstrual disorders, it is including men, so that you as a man you understand, why is my woman behaving like this? What can I do to make my woman happy? A woman that gives me love, a woman that makes me feel the way I feel right now. What can I do to this period to make this woman feel better? Yes. Tomorrow we will be dealing with premenstrual dysphoric disorder, and then, if time will allow, because these are huge topics, we will deal with substance medication induced depressive disorder. You see, those two are very specific and they are big topics. Hmm? Tomorrow we will learn how the menstrual cycle and hormones of the menstrual cycles, how they make a person feel moody, how the uterus makes you feel pain as a woman. What can your man make you do to make serotonin to come up to make you feel relieved and psych up? Hmm? Yes. Thank you very much for the learning today. I've seen my friend that they are the killer, picking a big up Roger Killer on the platform. We thank you for being with us. And we have talked and said we are not just dealing with mental health alone. If you have a problem, medical problem that you are undergoing, and it has been disturbing you for long, and you want to understand the problem well, yes, you just ask us. What? There are so many issues that are out there. I've seen there are people who are suffering from diabetes. Yes, that's another line of medical health that we are going to deal with. There are some people that are dealing with hypertension. I've been asked so many questions about hypertension. Yes, be ready, that time is coming. We are trying to set up things so that we'll be having some 2 or 3 videos a day on these issues. But now we are dealing with mental health. Let's help our people have good mental health. For all our supportive structures, we have seen the neck and ankle. Yes, big up. So thank you so much. And others, we thank you so much. My friend, I am Marwa, where you are. Everything is going on. Good. Thank you so much. Thank you for listening. Today's topic has ended there, and I've said if you want to understand well where we are, because we started somewhere, go back to the previous videos, understand the generation of these topics step by step. By the time you reach where we are, you will be understanding why this. But if you are not understanding any bit of anything, just ask. It is very important to ask a question. You understand. Get a written document sent. You understand. Most of our topic comes at 12 noon Kenyan time, East African time, 12 noon to 1. But if you have more topics, like 2 topics, we go up to 2. So for today topic, we have dealt with 2 topics for children. Tomorrow, next time, which is tomorrow on Friday, we will do premenstrual dysphoric disorder. And before we do it, we will learn about the uterus and how menstrual cycles come along. Very important. If you have a lady who is suffering from these problems, please bring that lady tomorrow to the platform so that this lady may understand why she's having pain and what she can do. Because many ladies are really suffering when it comes to this monthly. So welcome again. Welcome again. Thank you. And be blessed and stay cool. Bye.